welcome to this latest ASME Bite Size. We'll be looking in this ASME Bite Size a little bit at large group teaching and thinking a little bit about how can we deliver effective remote large group teaching, particularly in the time of COVID. Many of us are very familiar with delivering large group teaching, and we've had to adjust that. Coronavirus has forced us to do a lot more remote teaching, get familiar with remote teaching technologies, and some of that has been a challenge, but it's also been an opportunity. It's been an opportunity to think about, well, how can we do this differently? It's forced us sometimes to think about, well, what's the evidence? How can we do this most effectively? Well, how does the scholarship inform what we do? And so the purpose of this ASME Bite Size is not for us to tell you what we think you should be doing, but we want to get a conversation going. We want to work as a collaborative group of medical educators to improve how we all deliver remote large group teaching. So the purpose of this first session is we're just going to introduce some thinking. We're going to discuss a bit about the lessons that we've learned from our experiences. We're going to look a little bit at some of the underlying scholarship. And then we want to have a follow-up session on the 5th of August at 4:30, which will be a bit more interactive. And we want you to join the conversation, bring along questions, ideas, thoughts, and experiences to that session. And we can pick up a little bit more about how we can develop large group teaching going forwards. So that's the plan. We're going to look a bit at how we currently deliver large group teaching, what the scholarship shows, and a bit about lessons that we've learned from our recent experiences. So we're going to do about half an hour now, and I'm going to introduce who we are. So I'm Mark LILLICRAP. I'm a rheumatology consultant. I deliver quite a lot of large group teaching here at the University of Cambridge. I'm the sub-dean for the curriculum, and I sit on the ASME board. I'll let Claire introduce herself next.
Hi everybody, my connection with Mark and Jeremy is I lead the master's and diploma stages of the medical education programme at the Institute of Continuing Education at Cambridge, and I also happen to be the chair of the ASME Education Research Committee.
Hi, and I'm Jeremy Webb. I work with Mark as a clinical sub-dean at the School of Clinical Medicine, where I have particular responsibility for staff development, which means that we run a foundation programme for medical educators and also the postgraduate certificate. My clinical background is I'm a GP, and I also teach graduate medical students on a weekly basis.
Excellent. So we're going to kick off just by thinking a little bit about how do we currently do staff development for large group teaching? And so I'm just going to give a few pointers just to trigger a bit of our own thinking about large group teaching. So what I'm going to do is I'm going to go through a brief presentation that summarizes some of the stuff that we would talk about in our staff development programs for our faculty about how to deliver effective large group teaching. So delivering large group teaching. So in terms of the things that we would routinely think about with our staff development when we're talking with our lecturers are to think about your lecture, well, a little bit like a good meal. We want to think about a starter, a main course, and a dessert. And we think about how do you attract attention? How do you activate learning amongst the students in your large group session? How do you maintain attention as you go through the session? And how do you ensure that learning has taken place and promote future learning? So whenever we're talking about large group teaching, largely in a lecture kind of format, we get our lecturers and teachers to think about those key areas. And I suspect most of you who are listening to this will have come across this kind of framework in either how you prepare your own teaching or in terms of staff development, faculty development sessions that you've done yourself. Let's just unpick those three areas in a little bit more detail. So attracting attention. So there are a variety of ways that we would advise lecturers to think about how to get a session started, how to grab the attention of the audience and engage them a bit with activating their prior learning. Often we'll talk about using anecdotes or clinical cases to get that started. We might advise people to think about a short video that introduces a key area. We might present a clinical problem or an interesting fact. We might give them a short quiz at the start, 1 or 2 single best answer questions to, again, just activate a bit of learning before we kick into the rest of the session. There are a variety of tools that we'd use in our lectures to survey the audience's prior knowledge, to think about attitudes if we're thinking more around large group professionalism teaching. And we advise people to think about, well, what's going to be relevant to what you're covering next, and what's going to be relevant to the audience and the students that you have in front of you. When it comes to the main course, how do you structure the main session? And there's a few key areas that we would routinely advise our lecturers. We advise our lecturers to be aware, less is more. Limit the amount of information that you're giving. Think about chunking the content. Chunk the content into sections of 10 to 15 minutes each. So that you have regular breaks as you go through the session, and that allows review time. If you put pauses, silence, quietness, other activities in to break up your session, that facilitates student learning and enables you to maintain the concentration of the students. Sometimes you might have short quizzes. You again might use things like single best answer questions to help with that. We talk about the importance of concentration span, being aware that after about 10 to 15 minutes, you're going to lose your large group concentration. So you need to change their focus of attention. You can do that by having more than one of you facilitating. So you change the focus of attention. You can do that with pauses and gaps. You can do that with activities. But you need to think about that in your structuring. And in order to facilitate having those gaps, you usually need to reduce how much content that you think that you're going to deliver within the session. And then finally, how are you going to promote learning? We encourage our lecturers to think about, well, what are going to be the 2 or 3 key take-home messages that you want your students to take from the large group teaching session? And you want to make sure that links with the initial objectives that you defined at the start of the session. You want to think about, well, what about those activities that you are embedding in the chunking of the session? Do they reinforce those points? Have you structured your large group teaching session to facilitate that? And encourage your students to write down what they've learned. So encourage students at the end, give them time to reflect on, what have I learned in the course of the past hour? What do I want to read up on further? What are the key things that have challenged me in this session? And ideally, you want to evaluate that yourself, and you want to find ways that you can access that information. We encourage our lecturers to think about using post-it notes or getting students to write things down that they then leave with you, so that you as the lecturer can see, what did my students learn from this session? Because the key thing that we discuss, it's not what you teach that matters, it's what your learner learns which is important. And I guess that's the key thing that we all need to think about as we migrate from classic lecture-based large group teaching to the alternative, which is what we're all having to think about, which is that remote large group teaching delivery. We're all getting very used to having to use various remote teaching platforms in order to deliver large group teaching. And it's clearly very different. It's got different challenges. But as we mentioned at the start, it's also potentially got some great opportunities. How can we deliver the most effective large group remote teaching? We want to promote the scholarship. We want excellence. That's ASME's vision, to promote the scholarship and excellence of medical education. And we want to work collaboratively. So what we want to pick up on is, well, how does the scholarship inform this? Is there evidence from prior scholarship that we can utilize as we're redesigning and reconfiguring large group teaching sessions to be remotely delivered? That will be useful for us to think about. And so what I'm going to do at this point is I'm going to hand over to Claire, and I'm going to get Claire to just talk us through a little bit about, what does the scholarship teach us here? Is there anything from prior scholarship that would help us deliver more effective large group teaching? Claire, over to you.
Thanks for that, Mark. So those who know me will know that I'll probably start by being a little bit provocative around this. And I think the first question I have been pondering with is actually, what's the point of lectures? Why are we doing them anyway? Why are we doing them face-to-face, and why are we doing them remotely? And one of the things that happens is, if we accept whole scale that that's going to be our mode of delivery, we can get very hooked into the mechanics of the delivery, the efficiency of the delivery, the effectiveness of the delivery. And whilst I think they're really important things to think about, for me it's always going back to, well, let's think about learning first, and to what extent are lectures a good vehicle for learning, and more importantly in this context, what are their inherent limitations in terms of learning, and therefore how can we find our workarounds with that. And there are a number of ways in which you can go into that. There's a very good paper that was in Perspectives of Medical Education, which has said basically what would happen to medical education if we took the evidence seriously. And it's a lovely paper by Kees van der Vleuten and Eric Dreisen, so big names in medical education. And they basically synthesize the kind of scholarship of learning. And they say, if we're going to take the education evidence seriously, we need to think about, in any form of teaching and learning, what are the opportunities for students to engage in thinking behaviours? So not just receptive processing information. We know they're very good at that. We know that they're good at taking large amounts of information and processing it. That's how they got into medical school in the first place, and they're very efficient. So what are the other types of thinking behaviours that we want to promote in teaching, and can we do that in lectures? And so they talk about opportunities for elaboration. So the lecture perhaps being a place where it's possible to elaborate upon ideas. So we then have to think about, well, what do they need to do before, or how do you set that broad landscape of a topic so that there is an opportunity to elaborate upon ideas and to develop, for example, a narrative, a story, or an argument. Good learning involves cooperative learning, so there's opportunities for dialogue. So are there ways in which, before, during, or after the lecture, whether face-to-face or remote, that we can foster dialogue, whether it's an internal dialogue, so setting them questions and quizzes and all those things that you've already talked about, Mark, or whether there are ways in which that we can create spaces for them to talk to each other. And in remote learning, that's often about letting go of control, because there's no way we can then check in on every conversation that's been had, but we can create spaces where they can have conversations. And I suspect Jeremy will talk a little bit about how you do that. Good learning involves feedback, so feedback to learners. So it might be we're having to do that through group work, or we're having to do that through quizzes. But it also involves processes of engagement. And I think one of the things learning theory leads us to think about is not only how do we make sure that students have the knowledge, it's how do we help them put that knowledge to work? How do we help those students make connections between that knowledge and the clinical environments that they'll encounter, the patients they'll encounter? So in a sense, how are we going to bring the clinic into the classroom and give them opportunities to see how whatever that is you guys are teaching has got meaning and relevance? And that's something that you can add that a textbook can't. It's something that they can't naturally go and scurry around and find. And the other thing is about how we make sure that we position learning in a social context, so that they understand that in coming together and thinking about medicine and thinking about medical practice, it's not only the content, we're also engaging with processes of professional identity formation and becoming and belonging to something that you weren't already part of. And actually a lecture is a good place for socialization. And I'll perhaps sum up that from another paper that I was looking at, which actually was from out with medical education. It was from the higher education literature. It's a paper by Sarah French and Gregor Kennedy. And they were looking at the role of lectures in contemporary higher education, because they were saying there are so many challenges. They fight against us in terms of everything we know about good learning. The lecture is not a good place for that to happen. So as lecturers, we have to work particularly hard in a lecture. And if we're doing it remotely, we have to work even harder. So why bother? You know, why would we bother to continue with lectures? And I thought what they say is highly relevant to medical education here, because they talk about things like cost-effective modes of delivery and, you know, being able to provide content and structure and up-to-date research findings and those kind of things. But they do emphasize a number of things. And there's a couple that I think are worth thinking about. Is they allow you to offer sustained argument and narrative, and that links to the idea about argumentation, that in fact you can contextualize the knowledge, you can help those students make connections, you can help them see why it matters to know this stuff more than just simply passing an exam. You can rehearse them in a whole load of skills that are really important for clinical work, so that you can rehearse them in note-taking, in active listening, in reflective practice, if you're confident enough to create the spaces within the lecture to allow them to do that. And the other thing I thought was you can model behaviour, you can model thinking behaviour, you can model professional behaviour. This is how we approach our work with patients who present with these conditions, about the language you use and how you talk about your work. And then the last one of their continued value of lectures, and I think it's one thinking about, is they describe them as a social event that produce and reproduce a sense of shared communal understanding. And for me, that's perhaps one of the most powerful things of lectures that we don't necessarily explicitly embrace, that this is a space where you can lay out the landscape of this is how we think as doctors, this is how we work as doctors, this is how we approach this particular field of inquiry. And for that, they're really powerful. So that's all I would add to the mix at this particular point.
So although it might take us out of our comfort zone a little bit, then the remote teaching actually offers us the opportunity to develop some of those areas more effectively.
Absolutely.
Yeah. So I'm just going to hand over to Jeremy at this point to give us a little bit of an idea about practical tips that you've obviously you've been delivering large group teaching during the sort of lockdown time. Just a bit about how you've learned some lessons picking up from what Claire's been discussing about the scholarship.
I think we'd like to emphasize the importance of planning process as much as content. And the thing, I've co-taught with Claire a number of years, and I always used to put content first and process last. Claire has convinced me the need, and I think remote teaching has made it even more. What do you want them to get out of this session? How are you going to plan the session to deliver that, and then put the content in at the end? But in fact, I say content at the end. I think we're putting a lot of content in at the beginning. So the thing that I have found worked well, and the students have loved, is the fact that you pre-warn them what a clinical session is going to be about, and you give them some stuff to look at beforehand. So now, if I'm going to be running a teaching session, I will say to them, on Thursday, we're going to be discussing abdominal pain in children, for example, and here are some things that you might like to look at. So you might like to look at this chapter in this pediatric textbook, or you might like to look at this video of a patient describing their experience of presenting with abdominal pain. And you can get videos quite easily online. So if you just search things, for instance, like inflammatory bowel disease, I came up with a fantastic video of a child presenting for the first time with abdominal pain who's turned out to have Crohn's disease. And she gives a narrative of how she's first presented and then has been managed since that time. There's some fantastic resources out there. So Patient Voices is a really good one for giving the patient's perspective of an illness. If you want more specific clinical ones, then we use a thing called Speaking Clinically, which I think came from the University of Bristol, which is an amazing resource where you can virtually search for a particular condition and you'll find a patient with that. And we now preload all of our teaching content, our teaching sessions with something in advance to get them to look at. The other thing that you can find is if you want to go back to basic science or relate a condition to basic science, there's some brilliant web pages, a lot of them from the US, where people actually have an ambition, they can draw out things and show spider diagrams and plot out their clinical reasoning and their thinking, which the students have loved. So we've broken down, when we've been running our own teaching sessions, what we call before, during and after. So like Mark's meal. So the before is the starter, where we give people the ideas about what's coming up to whet their appetite. The during then becomes much more of an interactive session where we don't teach so much content, but we build in ways of interacting with the students. And then the after is where we might point them to further resources that they want to go to. But as Mark also pointed out, encouraging them to reflect on what they've learned and what they've covered. So we actually give them time to write things down, or say before the next session, what are you going to go and look up? What are you going to read more about? So that's the sort of general thing about teaching, the way we've approached that. And that works well for small groups as well as larger groups. There are some particular things with larger groups that you need to be aware of that I think are very different. And Claire and I have run a number of large group sessions together. We feel that actually running much more than 25 on your own is really difficult. And co-facilitating is something that we found is really useful. So if you've got the option to have somebody else with you, then take it. even if they don't lead the session, if they can monitor things like chat, and you can prime your students to use the chat facility on the virtual platforms to put in questions, then you can stop every 5 minutes or at the end of a particular section and then draw in questions. So that involves the students.
Mm.
We've also learned to use breakout rooms, which are a facility which we find really useful. And the evaluation we've had from our learners is that they really enjoy that, and we should be doing that more and not less. Claire, you've, I think, had some, when you were interviewing for the PG diploma, some of the people on the certificate talked about that. Do you want to just share that with us?
Yeah, I think one of the context of our large group teaching is obviously people doing things like certificates and diplomas in medical education. So it's a particular context for large group teaching, or remote teaching more particularly. We did run some pre-record sessions that we had this kind of dialogue, and they really enjoyed them. They enjoyed the fact they liked it best when there was discussion between us, where it felt like that there was an authentic conversation going on between faculty. They really appreciated that. But they said what it didn't allow them to do is have that space and time to think the things through, to talk them through with each other, and to kind of develop those ideas and actually put them into their own particular context, because obviously they're from all specialties, all stages of medical and dental careers, and they felt that the real value that they had in the face-to-face teaching was being with peers, so they could say, what do you think about this idea, or do you get this thing about that, or I'm not sure how that would work in my context. So I think, and they felt that in a sense that we were maybe a bit too rushed to kind of put them in their breakout rooms and then not pull them back again, or we were pulling them back too rapidly. And that's something we're certainly thinking about, and not only when in breakout rooms for formal kind of structured activities. They're saying it's nice sometimes just to have a bit of space to catch up with people, to talk about what they've been doing since the last time that we had teaching, or, you know, talk about assessments that are coming up. And so for our next year, we're beginning to think about how do we create some spaces for that kind of peer collaboration, that kind of social kind of dialogue, that we don't have to be in charge of. So I think that's quite an interesting thing as the educator, to kind of relinquish control, really, to create those environments.
And I think that is something that we both found, you know, the fact that you feel a bit out of control when you're using breakout rooms.
Yeah.
The other thing with breakout rooms is a lot of them just allocate the students randomly to the breakout room. So if you want to do some pre-course work, you need to be able to use the non-random distribution, which takes a bit of a skill, because you need a list of who's coming beforehand.
Yeah.
And I'm running a clinical session next week, and I've been thinking about that. And I decided it's for first years on the use of common drugs. I've just done 5 different cases, and I'm going to break them into 5 groups. And I need to work out, you know, who's going to be in which group. But you know, it does take some planning. And question is, how long do you leave them to discuss things in the group? Because you then feel a bit redundant. You can go off and make a cup of tea yourself, and they're still there when you come back. But you can dip in and out of the rooms, which is I have happened, but occasionally it crashes the system, so you just have to be aware of that.
They can ask for help as well.
Yeah.
Can I go back to your example of what you were doing with the lectures, Jeremy, with the clinical students? Because I think you made some really lovely points there about that before, during and after piece that so clearly echoes the paper around taking the education evidence seriously. Because in a sense, what you're saying to them is, look, this is what we're going to be doing. Here are some things that you can do. You gave them a choice, so there's some independence in terms of, well, I might read the chapter, or I might watch the video, I might do both. But in a sense, you're giving them an opportunity to kind of get a first sense of the field, a first sense of the topic to be discussed. And then you're very actively saying to them, in doing that first, we can use the time wisely. And in using the times wisely, and you talked about opportunities for interaction or discussing cases, you're doing that piece of elaboration of ideas, you're doing that piece of collaboration, you're putting it in a social context, and that you're doing mentoring in its broadest sense is that you're helping rehearse them in ways of thinking through the patient presents with an abdominal complaint. And it does in a way feel counterintuitive. And often if it's set up to be a large group or a lecture or remote, we get very hung up on, or what do they need to know? What am I going to say? But if you've decided that beforehand and said, look, this is your starting point, do your homework, folks. And then you authentically engage with it. Because I think the trouble is, if you say, do this work, and then you actually then just deliver a lecture, they're like, what's the point? And actually I could go and look at it afterwards, because you might as well just record it, because then what we know with pre-record is actually they quite like pre-record because they can stop it. They can rewind stuff they don't understand. When you're burbling on like I am now, they can go at 2 times the speed. You know, that they actually have more control of a recorded lecture. So it's about being confident. If you say you're going to use the time to think things through and discuss and interact, you have to do that. Because if you don't, then you've let them down. And next time they don't.
I think you need, it's a matter of priming the student. So I think it's really important that so what they do is they don't just look at the video and read the chapter. What we use is what we call advanced organizers. So we say, look at the video, and whilst you're viewing it, think about the following. For instance, the one with abdominal pain. What other conditions might this child have who presents with abdominal pain? What were the consequences of her having to have steroid treatment? What did she describe?
Yeah.
So they've actually got some pointers. And then when we start the talk, we actually do put up a list of intended learning outcomes so that they know roughly what we're meant to be covering in that time. Yeah. So you try and match those to what you've done already, so that you're already because otherwise they could look at the video and pick up completely different things to what you feel are the important things they want to cover.
Yeah.
But I'd pick up, so there's sort of 3 areas that I think you're highlighting that map to the scholarship, and the first of which I think picks up beautifully on the second paper you were talking about. It's that social event, and actually part of our responsibility as large group facilitators and lecturers is to create a social event for learning for our students, and that may involve interaction, it may involve cases, but we need to think about that, and we need to plan for that. The second thing picks up on the importance of reflection within the process, and actually having times of space, and space to discuss with peers, space to just reflect on your own. And as you highlighted, Jeremy, there's something about having to let go, and not necessarily feel that you're always in control, because actually, again, mapping back to what Claire's discussed around the scholarship, that's what a learner needs in order to effectively learn within that large group context. And then the third thing is about how do we embed within clinical teaching the patient voice, and how do we get a patient-centered approach to large group teaching, which things like speaking clinically, patient voice, very much maps to what we were discussing with Selena Robertson, the John Ellis Prize winner, around patient narratives. And actually, how do we utilize effective patient narratives to frame our thinking, be it clinical reasoning, be it professional practice, be it basic science, be it therapeutics. And so they would be the sort of 3 themes that I think have emerged: thinking about the social element, thinking about providing space, and thinking about the patient element.
Lovely.
Claire, was there anything else you wanted to add in terms of the scholarship from what we've discussed?
I think those 3 points are really powerful, and I think, and actually, I'm thinking of yesterday's webinar was on social accountability, and there's some really interesting discussion about the purposes of a medical education and who are we serving here. And I'm a great proponent of, how do we help our students make connections between their knowledge and how they put that knowledge to work, and how do we rehearse them in ways of thinking. And there's a really old, it's quite an old paper now, it was from Brown and Minogue, and I think it's actually an AME best evidence medical education on lectures, but it was interesting, they did a study of medical lectures and dental lectures, and they looked at structure, which seems like a really simple thing about how you structure a lecture. And they said most lectures were structured on the kind of classical iterative structure, which is like you'd see in the Oxford textbook of medical education. So it's kind of signs, symptoms, and and we all know it, and we all know what's coming next. And they go on to suggest other ways in which you might structure, whether it's a problem-centered lecture or a comparative lecture. And what strikes me about these alternative modes of structuring is that we, rather than saying, patients present in this linear way, so they present as a textbook. So as long as, you go, is the abdominal pain this, dum, 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 no. So then you go back to the beginning. Actually, what you do as clinicians is something much more sophisticated. So rather than doing it that way, you do it that way. this looks like a this, but in the back of my mind, it could be a that or a that. So what would be the difference between it being this or this or this? Well, we'd have to look for this and we'd have to look for this. So that paper is worth a look at just in terms of other ways of structuring a lecture, which again, then rehearse the students in ways of thinking like doctors. They can find classical iterative anywhere. They read the Oxford textbook chapter, done deal. But actually it's not knowing that stuff, it's how do we know when this stuff is relevant, but also how do we know when it's not relevant, when we need to bring in something else. So that would be the, with those three very succinct themes, I think that's the other one that I'd point people to.
And obviously all we're doing, as I say, we just want to get a conversation going. We're learning from our own experience, and we want the community of medical educators that is ASME to share ideas. We've also made mistakes, and we've learned from our mistakes. It's very easy, we've discovered with remote teaching, to make mistakes. Jeremy, you had a few other just sort of practical tips about using things like Zoom and Teams when you're delivering large group teaching. Over to you.
Well, I suppose first one, as we've demonstrated brilliantly, is mute and unmute.
Yeah.
You want everybody to, in a large group, you want everybody to be muted when they're not speaking. Otherwise, you get the dog barking and the Amazon man turning up.
Yeah, sorry about that.
Just as we started doing this. The other things I think we probably ought to talk about, co-facilitation is definitely worth thinking about, particularly if you're going to be running a particularly large group. Otherwise, it becomes a bit unmanageable, because if you are using a PowerPoint projector, then you can only see 4 or 5 people at once, and so it's very difficult to monitor what's going on in the room. If you're recording a session a bit like we are now, the thing that I was taught last week, which I've now found much easier, is that you don't have to have your own face on the recording the whole time. To me, there's nothing more off-putting than having to look at myself talking. So at the moment, I'm looking at Claire, which is fine.
Yeah.
When I look at myself, it's terrible. So what somebody taught me last week is actually it's really useful. Show your face and introduce yourself. But when you're actually doing your talk, it's probably okay just to turn your own video off so that you don't have to view yourself. So I found that much easier, because that's much more what I would be doing face to face. I don't have to look at myself unless there's a large mirror in the room.
Can I add to that one, Jeremy? Because on the diploma, we actually had somebody I was working with who did a demonstration of coaching, and she was coaching over Zoom one of the participants on the course. And what she got them to do was we have cameras on the diploma, so we have on mute unless you're talking, but cameras on so you can see, because there are only 20 odd people. But she just got everybody to turn their camera off other than the person that she was coaching. And it was so powerful because everybody's gaze was on the interaction between the two and you weren't being distracted. So I think judicious use of camera on and off, depending on need, obviously more than 25 or so, it becomes you're scrolling between screens, and that's hard work.
I think, Mark, you also mentioned the thing that Lawrence Sherman talked about with the ASME session, where he talked about standing up, because one naturally teaches standing and doesn't sit the whole time. I'm aware I'm doing this the whole time. I'm putting my arms up and down. And if you turn your camera off, you can actually stand up and walk around the room. But it does mean you have to have decent audio. So Mark and I have both bought a large microphone, which I will demonstrate now, which comes with the cost me about 40 quid on Amazon. If you're doing lots of this, I think having a decent microphone is useful to think about.
Yeah, and I'd add, certainly if you're used to doing a lot of large group teaching and you're used to doing lectures, you're probably quite used to standing up to deliver that. And actually having the camera off enables you to stand up. And certainly I've found when I'm doing pre-recorded large group teaching, the sort of the asynchronous large group teaching, I feel much more comfortable standing discussing my my presentations than I do when I'm sitting down, which is much more of a small group kind of interaction feel. And so make the most of that opportunity that you have with the various remote teaching tools that are available.
The other thing we talked about was thinking about content, how you're going to break up content. So that can be using things like breakout rooms. That's one way of dealing with it. The other is to put in a little quiz or some MCQs or single best answer questions which mirror what they're going to get in assessments. Medical students really appreciate those. But then you can discuss why people have got to those answers. And when you're questioning people, we encourage the use of the 1-minute preceptor type model. But I think the thing to be aware of is that on Zoom, that could be quite intimidating. So if I suddenly said, over to you, Claire, take me through that, it's a bit like, oh my God. So you have to be a bit careful that you're not pouncing on people. And it can be more so than when you're in a room with them, because you can monitor the quiet ones in a room with them. That's the advantage of the co-facilitators. They can be keeping an eye on who's going on. One of the things I've done...
Equally, that sort of addressing single best answers, unpicking the reasoning, discussing that actually is a really helpful way in a large group setting of creating that feel that this is a learning event, that it's got that mentoring support element to it, and actually you're not just discussing the standard iterative stuff, you're going more into how do I think, what's going on in my mind in this situation, how do I approach this. So I think they're really useful tools that again just map to the evidence. And if we're starting with, as Claire's highlighted, the sort of blank canvas as to why do this large group teaching, I think it's a really good thing to embed.
The other thing I'd point out is,
Claire.
I was just going to add to that, you can use other technologies as an adjunct. So if you're confident with other technologies, and certainly I wouldn't do it without a co-facilitator, so you could run an interactive tool, like whether it's, I use Slido, but there's things like PROF, other interactive things are available, that it allows them, so in some of the platforms, there's things like a polling function, but they're not sophisticated. But you could run that in parallel. And I think if it's students that you're going to work with over a period of time, so it's not a one-off. For a one-off, it's an awful lot of your time and space with them is setting it up to use them. But if you set a culture that whenever we do this, there's a Slido, for example, running in the background where they can ask questions, or you can get them to do a think aloud, you can do a word association. There's a whole load of different things you could do in that. You could run that, but that's where you do need a co-facilitator, because there's, again, nothing worse than saying to the students, interact with us, want you to put things in the chat room, ask us questions, and then you totally ignore it because you realize you actually haven't got the capacity as the person facilitating the teaching to do it. It's too much going on, you're overstimulated as a teacher. So actually having somebody quietly in the background curating the interaction is really powerful.
And if you're really good, then interactive whiteboards are fantastic. There is a whiteboard on Zoom, for instance, and I'm sure there are in the other platforms. But you can actually plug your iPad in and use a whiteboard. So in the same way as you might use a flip chart to draw things out, which it avoids the death by PowerPoint. And I think feeling that you have to put a PowerPoint up all the time is not necessarily the best way of doing things. And we've created a space on our VLE called Virtual Medical Education Lessons Learned, which has got lots of these tips on it. And one of our PG Cert applicants has done an amazing presentation where he's done a whole 20-minute talk just using whiteboard, where he draws things, and it's much more powerful than using PowerPoint. I think the only other thing we're going to put, Claire, is the use of silence. It's okay. In the same way as silence and waiting time is something you need to think about when you're teaching face-to-face. It can be a bit unnerving on remote platforms, but using silence. The final thing I was saying that was the last thing that I'm quite used to doing is I keep a notepad by me on the computer. And actually, if I'm teaching a group of 20, I will write their names down from the participant list. And then when I get a question from them, or I have asked them a question, I'll put a tick by it, so that then I can then make sure that I've been trying to include everyone, because the electronics tends to be, if we were here, Mark Lillicrap's picture would be at the top the whole time, because he would probably be the biggest contributor as a student. And you
don't say.
You get exactly the same with the student. So the ones that talk the most are the ones that appear, and it's the ones that aren't appearing that you need to be aware of. So that's something, just a practical tip. Just a bit of paper and a pad and pen by the side of you is invaluable.
I'm going to try that one next time I do it. Thank you, Jeremy. I like that.
Okay, so we've looked a little bit at different aspects of large group teaching. We thought a bit about, well, how would we approach conventional lectures? How would we advise somebody to do that? We've looked at some of the scholarship and what the scholarship can teachers that will be useful to apply in remote teaching. And we've thought a bit about the practical elements of delivery. What practical tips have we picked up? As we said at the start, we don't anticipate that this session is here to tell you exactly what to do. We want to get a conversation going, and we want to get examples of good practice from other areas. If people have been doing research work looking at remote teaching delivery, it'd be great to hear from you. And so what we want to do is follow up this conversation. You're going to get some communication from the ASME office about the details. If you want to submit questions or ideas in advance, we'll be meeting up for a live Q&A interaction on Wednesday, the 5th of August at 4:30 for about 45 minutes of discussion. So do try and join us for that. That will also be recorded, and you'll be able to access that afterwards if you're not available at 4:30 on Wednesday, the 5th of August. We hope, if nothing else, we've triggered some thinking. We hope there's some ideas there that you might want to take away. How are you going to create that social experience of the large group teaching session? How are you going to allow interaction? How are you going to articulate thinking? How are you going to introduce gaps and silence and quiet into your next large group teaching session? We look forward to joining a number of you on the 5th of August. Otherwise, thank you for taking the time to listen to this presentation. Bye.
Thank you very much. See you soon.